Welcome everybody, and thank you for joining 3D Systems webinar. In this webinar, we will discuss the aspects of prosthetic artery embolization. I appreciate you joining us today, and I hope you will be able to join us for future webinars as well. My name is Shani Fargun, and I'm a product manager in the AngioMentor Simulator team. I will be the moderator for today's webinar. The webinar outline is presented to you on this slide. We will start with the AngioMentor and the PAE module. After that, we will go through prosthetic artery embolization indications, the technical aspects of the procedure, the training challenges, and finally, we will see a simulation demonstration over the AngioMentor. A few housekeeping items before we get started. As you may have noticed, all attendees' lines were muted upon joining the webinar. Therefore, please use the Q&A button on your right-hand side of the screen to submit any questions as we go along. We will do our best to answer all questions at the end of the webinar. Some tips for best webinar experience: please close all open windows on your desktop. For improved video display, click on the full screen button. And finally, in a couple of days, you will be receiving a follow-up email with a link to view the recording of this webinar. Before clearing the stage for Professor Carnevale, I would like to familiarize you with the AngioMentor training platform. Our AngioMentor virtual reality simulator provides practice opportunities for over 30 different endovascular procedures for individual and team training, with over 300 cases used for training of multiple specialties. The PAE module, which will be presented on the simulation demonstration today, has many features and educational aids. First, the user can select a desired approach, radial or femoral. The user can also select various sizes of embolic agents. As you can see here, we will see an indication of the amount of embolics injected and the percentages of the block in the prostate. The anatomies are based on real patients and are realistic and complex. We can also practice protective coiling on different branches that lead to other anatomies other than the prostate. And finally, we can see anatomy labels that helps us to identify the inferior vesical artery. And now, the moment we waited for, I am honored to present our guest speaker, Professor Carnevale. It's all yours.
Hello, everyone. It's a great pleasure to be here and honor to participate with 3D Systems Symbionix, explaining to you the simulator and device and the role in prosthetic artery embolization. So today we have the opportunity to discuss some important details on the prosthetic hyperplasia, the disease, and also the technique of prostate artery embolization itself. And after this, we'll discuss the importance and the role of the simulator in this amazing procedure. First of all, it is really necessary to understand that the LUTS and BPH, they have a close relationship. Benign prostatic hyperplasia is a high prevalence disease that usually occurs after the 50s. So it is a disease that is characterized by two main components, the stromal and the epithelial cell, and they work in conjunction, causing an obstruction of the urethra because of the enlargement of the prostate. So this enlargement of the prostate, because of BPH, it obstructs the urethra and causes what we usually call lower urinary tract symptoms, and it occurs very frequently in men after 50s. You need to understand that LUTS is usually related to BPH. However, there are several diseases, as you can see here, that also can occur and can cause what we call LUTS. So it is really necessary to work in collaboration with your urologist to understand the cause of LUTS and identify if you have BPH disease or if you have any other disease that could be causing the obstructions. So when you are investigating LUTS, it is necessary to understand the most common symptoms that patients usually present. And all these symptoms, they are recognized and characterized what we usually call the International Prostate Symptom Scores, the IPSS. We have 7 important questions that can be add a number to each question. So here you can see that on the left side you have a question regarding incomplete emptying, frequency, intermittence, urgency, weak urinary stream, straining, and arteria. So all this IPSS will give you a number that ranges from 0 to 35, and it correlates to the degree of the disease. So the degree will give you a range from 0 to 7, that is mild symptoms, 8 to 19, moderate, and 20 to 35, that is the severe disease, severe symptoms. Usually, we treat patients above 7. And also, it's really important to understand if these symptoms cause any problem in the quality of life of the patient. So we also use the International Quality of Life Score that will tell you and will explain what is the importance of the disease in the life of the patient. So we usually ask a patient if they would like to spend the rest of their lives in the urinary condition that they have, what they would feel about that, how they would like to live in that condition, or if they would like to change that condition. So that's why we usually treat patients after using quality of life score after and above 3. So patients with good quality of life below 3, they are not treated with any kind of invasive treatment. So here you can understand that we can give orientations to the patient. We can tell patients to reduce the amount of liquids that they usually get, mainly during the afternoon and during the night, but also we can give medications. And most of these medications can give for patients with mild symptoms or also with moderate or severe symptoms. It is the first alternative of treatment that is a minimally invasive, that is called medication. However, this medication, they have some problems, some adverse events that patients need to be aware. After medication, we can move to other kind of treatments. And these treatments, they are usually offered for patients with moderate or severe symptoms, that is above 8. So here you can see that they have usually offered by urologists. They are minimally invasive treatments like ablations, thermal therapy using microwaves, laparoscopic, robotic, and also some stent or other procedures. So other alternatives of treatment is the urethral incision for very small prostates, also therapy, that is the gold standard mainly for prostate below 90 to 100 grams. And also there is a great number of alternatives using lasers, as you can see here, and also open prostatectomy for patients with very big prostates. So all these kind of treatments can be used by urologists. So it is really important to understand how to select your patient, mainly for when we are talking about prostate artery embolization as an alternative of treatment. Usually, we need to treat patients above 45-year-old, patients with moderate or severe symptoms, with weak urinary stream, and also with some patients that don't want to face the risk of complications or medical treatment complications and adverse events, and also patients with contraindications to surgery. So here we can say that all those patients are very good patients and candidates for prostate embolization. However, we need to exclude some patients that are not good candidates, as you can see here on the left side, like patients with cancer and also stenosis of the urethra, and there are some contraindications that we need to be aware and do not offer PAE for these patients. In general, we can say that indications for PE is when surgery is not an option, like contraindications due to the use of anticoagulations, antiplatelets, and also patients that refuse any kind of treatments, mainly complications, because of the risk of these complications and adverse events, and mostly related to retrograde ejaculation and urinary incontinence. So also, all these contraindications and adverse events to surgeries, they need to be discussed with the patient before indicating PAE. And of course, it's a demand from patients. Patients are aware about PAE because it's a minimally invasive procedure, and most of them are aware about this new alternative of treatment, and they want to discuss with physicians about this new option of treatment. So the protocol that you follow with your team and with urologists is based on the IPSS quality of life score. You need to evaluate the erectile index function. Your urologist should perform digital rectal examination, blood tests, ultrasound, prostate biopsy if necessary, and you need again to discuss with urologists. Sometimes, and if you can, investigate these patients with MRI is also important, and use uroflowmetry to observe and understand the urinary flow, and sometimes you need to investigate the bladder function using urodynamic testing. So moving to anatomy, that is one of the most important parts of this procedure and one of the most important concerns for physicians is the anatomy. So it's really important to understand the pelvic iliac arteries that could be related to the prostate. And here we give you an advice to use the acronym of PROVISO arteries. That is when you get your 5-French guiding catheter as the internal iliac artery using the ipsilateral oblique view, you can get and understand all these arteries. You can get a DSA arteriogram. You see the internal pudendal artery, the middle rectal artery, the obturator, inferior vesicle, superior vesicle, but you need to understand that you get this identification and correlation with the prostate only if you use the oblique view. And also, you can use the Foley catheter and fill the Foley catheter. You can place the Foley catheter before the procedure and remove after the procedure. If you use it, it will be a nice guide for you during the procedure. As you can see here, you have the Foley catheter that you can fill it with contrast, and you understand that everything that you have below the Foley balloon will be prostate or rectum. And there is a very nice identification of the prostatic arteries here using this technique. So there are mainly 4 types of prostatic arteries that cover around 95% of the anatomy related to the prostate. That is type 1, when the artery arises in conjunction with its superior vesical artery. The type 2, when it arises immediately below of the superior vesical artery. The type 3, when it arises from the obturator. And type 4, when it arises from the internal pudendal artery. And it is important to remind that when we have the type 4, in about 50% of the cases, we have a branch that feeds the rectum. So it is important to understand the prosthetic artery, the internal pudendal artery, and also the middle rectal artery. So in general, there are two main techniques that have been used in the world. The first one, what we call as the original technique, and the second one is the PErFectED technique. Both technique works. However, it is necessary when you are doing the PErFectED technique or the original, you need to place the catheter as close as you can to the prostate, and once you have the catheter very distal, close to the prostatic branches, you can identify one branch that goes directly to the central gland of the prostate, and another branch, there is the posterolateral branch that feeds the capsular region of the prostate, but also this capsular branch has several connections with the central gland zone. So once you have the microcatheter distal to any bladder branch or rectal branch, you can start your embolization. When you decide to do the PErFectED technique, is the time that you should advance your microcatheter deeper into the central gland branches and inject directly into this area to get more ischemia. It is important to remind that in this area is where we have the BPH disease. But after achieving this area, you should move the catheter back and try to advance in the capsular branch and get more embolics into this region to avoid recanalization and get more infarction of the prostate. It is really important to understand the anatomies because most of the complications are related to non-target embolization, and these non-target embolizations are totally related to the rectum, bladder, seminal vesicle, bone, muscle, and penis. So that's why you need to understand anatomy and understand the potential of complications for this procedure. And using simulators is a really very important tool that you have in your life to save radiation and to avoid complications to your patients. When you want to start your program using simulators, you can, if you have low case volume at the beginning, you are starting with your program. Using this will bring you great opportunity to understand the anatomy and to do the procedure safety, reducing radiation, and trying to deal with potential technical complications that you can have during this procedure and during your practice. So virtual reality simulation is really, really important for you to practice, to get a safe procedure, to train your procedure, and to reduce your learning curve, and to get better results when you're starting with prostate artery embolization.
Thank you, Professor Carnevale. Now we will move on to the simulation demonstration over the Angiomentor simulator.
So we start presenting a case of prostatic artery embolization in an elderly patient with 91 prostate gram. You see the MRI also that this patient has a big prostate, however nothing special. Is a patient that will select the material before the procedure. Also the access, you can use the femoral or radial. We will select the femoral approach. Once we select the femoral approach, also we need to identify the catheters, the guiding catheters. You can also use the Cobra. In this case, you have the Carnevale prostate catheter and other catheters that you also can use. 035 hydrophilic guide wire. And here you can see the introduction of the 5 French guiding catheter. through the right femoral artery. You cross, you can get a pelvic arteriogram, or only you can get an injection using fluoroscopy, using from the right to the left side. You see a beautiful image when you inject contrast. It's important to save radiation, so once you do this, you can identify both the right iliac arteries and also the left artery, and you are able to cross from the right to the left side using, in this case, a Cobra C3. So you use the contralateral perspective to identify the internal left iliac artery. Once you get that, you get a roadmap and you are able to catheterize the internal iliac artery. It's important to avoid advancing the guide wire and the 5 French catheter into the anterior branch of the internal iliac artery. So right now you move to the ipsilateral oblique view, trying to identify the PROVISO arteries. Also here in the middle you can see the balloon filled with contrast medium. Will be a nice guide, and you get a run. Once you get a run, you can see the PROVISO arteries, and also here you can see the prostatic artery. That is a type 1. So in this case, left side is a type 1. You have also the middle rectal obturator. So once you have this, you need to select microcatheters. We do recommend to use 2.4 or smaller than 2.4, 2.0, and 0.14 or 0.16 to catheterize. Here we have select an angle microcatheter, and we are able to advance into the prostatic artery. Once we get the microcatheter, you also can see on the left side, you can see the previous image that will guide you and will give you a nice orientation. Once we have that, you can get an arteriogram of the prostate, the left lobe, and start to inject nitro. You can start nitro before arteriogram, or also you can should start before particles injection. I do recommend, mainly for beginners, to use 300 to 500 microspheres. It's really important to avoid complications and get very good results. Inject the embolics very slow injection. So once we get this, you can get a stasis or near stasis. You see on the left side in microcatheter, you have a very nice injection under control. Once you get near stasis or stasis, you are able to do the PErFectED technique. So what you should do is to advance the microwire and the microcatheter until the transitional zone branches, and also if you are able, you can advance to the capsular branches. Once you are in that position, you can get a run. You can use microspheres to get this run. Is really a concern to do that, but you are able to do. But you are able to inject much more embolics into the parenchyma, as you can see here. You are getting very slow injection. I do recommend to use a 1 cc, and after doing that, you can pack the entire trajectory back until the orange of the artery. So now we have done this approach. Once we get this, you can move to the contralateral side. You can use the Wattman loop. Also, you can use the Simmons catheter. If you are using the Simmons, you can use the Simmons 1, or use the Carnevale prostate catheter, that is the CPC catheter, that you have 3 lengths of the CPC catheter in 5 centimeters, 10 centimeters, or 15 centimeters. So here you can see once we are using the Wattman loop with the Cobra, you are able to go up use your wire, avoiding getting any kind of dissection or complications, so you are able to move to the ipsilateral side. Once you get this positioning of the catheter, you know that you have the internal iliac artery, you get perspective, contralateral, and you get arteriogram here with the ipsilateral view. Once you have the 5 French, you see that this is a type 3 prostatic artery. Type 3 means that it arises from the obturator artery, so you are able to use your microcatheter and microwire, catheterize the obturator, advance the microwire into the prostatic artery, and once you have advanced, you are able to continue and get the arteriogram and get your embolization. You need to embolize very slow, and once you get this position, you can see that there is a catheter. So once you have catheterized the prostatic artery, you get an arteriogram, and in this case, you can see that there is some prostatic branches, and also there is a lower branch that go very distally. Once we see this artery, it's an artery that is connecting to the internal pudendal artery, so it will fill the penile and branch, and we have some connections. That is the situation that we should place a coil, and we usually use a detachable coil, 3 millimeter detachable coil that is very safe to use, and you can place it very safely distal to the prostatic branches. Pay attention, because you need to deploy this coil and avoid that the coil is placed very at the origin of the prostatic artery. So once we have deployed the coil, you have a safe position of your microcatheter. You have blocked any non-target embolization vessel, and you are able to do your embolization in a safe position. So inject very slow, and once you have injected your embolic agents, you get a control and you finish your case. If you have used the Foley balloon only as a guiding for the procedure, do not forget to remove the Foley after the procedure.
Perfect. Thank you for the simulation demonstration. We will now summarize the webinar with some tips and tricks, and then we will move on to some Q&A.
So to summarize that, I would like to give you some tips and tricks regarding the PAE technical aspects. And the tips and tricks are resumed in the prostate acronym, that is, place the Foley catheter and fill the Foley catheters with contrast medium 10 to 20%, and we recommended that mainly for beginners. Run a pelvic arteriogram to understand the anatomy, use the oblique ipsilateral view to identify the PROVISO arteries and also the prostatic artery. We should select and embolize all prostate feeder branches to the prostate to avoid recanalization to get better long-term results. Try to do the PErFectED technique, because once we have compared to the original, we have seen that PErFectED is much better than the original. Avoid non-target embolization using cone-beam CT, mainly if you have cone-beam CT, and of course using simulators. And take time to inject embolic agents. We do suggest to use 1 cc syringe and a very slow injection, and embolize both sides to get better results. And do not forget to remove the Foley catheter if you have used in patients that didn't have urinary retention. So we should place the catheter before the procedure, remove it. So it's a great pleasure to give you all these tips and tricks, and I'm here waiting to discuss with some questions and answers to you.
Thank you, Professor Carnevale, for an outstanding talk and demonstration. Before we finish, we have time to answer some of your questions. So let me read some of your questions here. Okay. So the first question here is, what PSA levels that mandate biopsy and contraindicate PAE?
It is a very important question. And first of all, I need to say again that it's important to work in collaboration with your urologist. So urologist will be the person who will decide about the prostate biopsy. However, we all know that as big as your prostate, higher is the PSA level. So we usually have patients with big prostates with very high PSA level. For example, patients with 100 to 150 prostate size, and they have a PSA of 5, 6, or 8. So this is not a contraindication. If you follow the guidelines, the AUA and European guidelines, you be recommended to get a biopsy over 4. So if a patient has a PSA over 4, usually they can get a biopsy. But it's important to analyze the PSA level that patient has during the former years. So if this patient has a PSA that has been high PSA for the previous years, it is not necessary to get a biopsy unless this patient had an increasement of the PSA. So you need to pay attention on that. And also, if you have any doubt about the cancer or something like that in the prostate, you can recommend and get an MRI. MRI will clarify this for you. So it is not a contraindication. High PSA is not a contraindication for PAE, and the decision is taken with your urologist.
Okay, and the next question is about the nitro. So can nitro open undesirable intraprostatic anastomosis? Should it be a routine or just in case of a spasm? And what dose and dilution do you use?
Yeah, another important question. We do recommend to use nitro, mainly if you have a very tortuous and tiny arteries with stenosis, with atherosclerosis. So once you get the microcatheter into the prostatic artery, if you have to deal with your guide wire, micro guide wire, to reach distal close to the prostate, we do recommend to use nitro or any kind of vasodilator. We recommend to use before getting close to avoid spasms and to get an easier navigation with your microcatheter. And also, we recommend to use before. Of course, you can open some shunts, but it's important to get nitro, and the dose that we recommend, you can get 100 micrograms. You can take 1 cc, that corresponds to 100, and get a dilution with 5 or 10 cc, so we'll have a total of 10 cc with 100 micrograms, and you inject 1 cc each time that you navigate. We also recommend not to open shunts, but to open intraprostatic vessels that will make the prostate receive more embolic spheres. So it's important to get the vasodilator. When you start to get your injection, it starts to inject very slow. We're using a 3 ml, 3 cc syringe. It starts to inject very slow. And at the end of the injection, once you were able to see the prostate, see the prostatic vessels, you put a stronger injection at the end of the injection. Because doing that, you can see if you are able to open any shunt any connection. So you start to inject very slow, and at the end, you put force in your injection to identify any shunt that could be opened.
Okay, another question that we have here is which microcatheter do you use? Which one is preferred?
My preference is to use the 2.0 microcatheter, a straight microcatheter. So you can use, I recommend to use any microcatheter for any company below 2.4 French would be okay, because using below 2.4, it would be easier to do the PErFectED technique, and we have observed better results using the PErFectED technique, and several groups in the world have the same experience. So we do recommend. You can use 2.0, the ProGrade, the 2.0, and also you can use the Maestro 2.1. In other companies, you can use the Echelon. Anyway, you can use any microcatheter below, smaller than 2.4 French.
Okay, another question that we have here is, from your experience, how many cases should be practiced on the simulator before the physician is prepared for real life? And are there such official courses available outside of Brazil? Because we are going to talk about one course in Brazil in a second.
Yeah, I believe that to start with prostate artery embolization, it needs to be an interventional radiologist that is familiar with pelvic anatomy and has dealt with different situations in IR in general, mainly with embolization. I think that if you're able to do 10 cases, would be great. A minimum of 5 cases will be okay. However, 10 cases in simulator would bring you an experience to work and deal with different situations, with different types of anatomies, from type 1 to type 5, and also with these different types of anatomy, you have the experience to coil and some collaterals. So using simulators is a strong and great experience, because we'll bring you all these expertise, mainly to recognize anatomy, to deal with different types of anatomies, microcatheters and microwires, and also coiling, identifying and coiling collaterals to avoid non-target embolization.
Okay, we have time for 2 more questions. So we have a question here. Which particles do you use and how do you dilute them?
There are different protocols that we have worked with. I do recommend to use 300 to 500 microspheres. Also, if you use smaller particles, you can get more ischemia. However, we have observed more adverse events and also more pain, so severe pain like burning, dysuria, when you use smaller particles, of course, because all these particles go deeper. So you need to be aware that it works, but you have higher potential for non-target embolization. And dilution, I usually add, when I use microSeeds, I usually add 10 cc of saline and 10 cc of contrasting medium. So I will get 50% dilution, 50% solution with 50% of each.
Okay, one last question. Do you use cone beam CT routine, or if you suspect any anastomosis or branches?
Very important question. I usually use cone beam CT routinely. There are several reasons for that. If you are using cone beam CT to identify the prostatic arteries and the internal iliac arteries, sometimes it's not necessary to get DSA. So you put your 5 French guiding catheter at the internal iliac artery. You get a run. You get a Carnevale CT with 3D rotation. It will be very useful to identify the prostatic artery and to guide it. So this is the first reason. If you don't have it and you don't want to use it, you want to use only DSA, you should use Carnevale CT when you have the microcatheter before doing embolization. You get a Carnevale CT, you see if you are covering, if you are achieving the entire prostate or not, and you see if you have covered with that artery the central gland, that is the region where we have BPH. And also, it will show you sometimes if you have any connection. It will give you an important view of this connection that would guide you to place a coil or to navigate distal to avoid any kind of complications. So my answer is yes, Carnevale CT is a really very important tool when you do prostate artery embolization. However, it is not necessary to use in every case.
Okay, thank you very much. If you have any other questions about today's webinar or the upcoming session, if you would like to schedule a demo of the angiomentor in general or even about PAE, please contact us in this email. I would also like to use this opportunity to let you know that there is an upcoming PAE course taking place in Sao Paulo, Brazil. This is a certificate course, and it will happen between the 7th and 8th of June. The course will feature also the angiomentor in simulation training sessions. We will send you a registration link after the webinar. Professor Carnevale, would you like to add anything else regarding the course or in general?
Yeah, I think that this course that is given several languages, it's Portuguese, in Spanish, and also in English. So it is a very intensive course. It's a 2-day training course with theoretical lectures with urologists, radiologists, and IRs. Also, you have an opportunity to see several edit cases and to work with simulators in different situations. Here you have 2 days to work directly with simulators with very experienced technicians that will guide you, will give all the experience, and also to participate in 6 cases. So 6 PAE cases that you have the opportunity to come to our country and to work and do the case, to scrub and participate in the case with us. So we have the simulator and you have the live case together in this course. So it is a great opportunity. You are very welcome to come here, and we will have this in June. This is the 3rd course, and we have other courses during the year. And please contact us, contact Symbionics and 3D System, and you can contact me personally. I'd be honored to receive you here in our country, in our course.
Okay, so thank you. The contact details are on top, and also, as I said, we will send you the registration link. This brings us to the end of our webinar. In a few days, you will receive an email with a link to the recording version of this webinar. Thank you again for joining us, and have a good day.